So let's start the session today. Welcome everyone. Today we have a keen speaker, which is Dr. Gabriel Constantinescu. He's one of the musculoskeletal radiologists here at King's. And he's gonna talk about elective hip replacements. And I asked him to keep it very simple for us to understand what should be taken into account when reporting metal work of the hip. So Gabi, welcome and go ahead.
Marcela, thank you for the introduction. And let's start with some basic things. Do not worry, there are no measurements here. They are just a sort of a little visual presentation with some few basic points that you should take home. Okay. What you should know, there are some common implants and prosthetic components that you will see during your stay with us as registrars and then as consultants. And they include total hip replacement, hemiarthroplasties, the cannulator screw, the DHS, and I left a little bit aside intramedullary nails because they're actually femoral shaft and femur rather than hip replacement has anything to do majorly with the joint in the hip. Let's go and detail a little bit of this total hip replacement and see what types of components you've got. You've got basically two types. One that is the resurfacing total hip replacement, where you only replace the femoral head and the acetabular cup, but you keep the femoral neck and the shaft intact. And the complete type of total hip replacement, you basically replace both the femoral component and also the acetabular component. So you basically get rid of the femoral head and the femoral neck, you replace it with a stem and you replace the femoral cup. There are two types, cemented and uncemented, and we're going to show examples of all of these. Now, once you have placed an implant, okay, there are a few things that the AP view tells you, and it tells you quite a lot, and you should make the most as you can do of this, because the use of CT, the use of MR, and the use of ultrasound is riddled with challenges from artifacts, from positioning, from lots and lots of other factors that impede your reading of this. Now, what are you looking for? And I'm going to advise you to keep basic, and I'll tell you what I think you should be doing and what I think you should let the orthopod ask you to do at a later stage. This is the bilateral total hip replacement, which is non-cemented. You can't see any cement here. Both cups. A few measurements that you can do pertains of the alignment. So what is the length of this limb, the length of the limb? You can draw a line through the trochanter's and to the lower part of the teardrop or the acetabulum and assess what is the length. You see, there is a discrepancy here, and the discrepancy is visualized without you having any need to draw and make sophisticated measurements. Remember, if there is a discrepancy of less than 1 centimeter, that is generally well tolerated and you don't need to do anything else. Other details like center of rotation, horizontal center of rotation, draw a line from here up to here and a line from here up to here. Vertical center of rotation, draw a line from here up to here. Acetabular inclination, you draw a line through this region of the acetabulum and then, and the vertical, and the horizontal line through here, and you measure the angle. It should be between 30 and 50. Please do this only if the orthopod is asking you to do that complex assessment alongside the version of the femoral prosthesis and so on. But another thing is important. Another thing that is important, if you look at the femoral stem and its incorporation into the shaft. If you look here, there is a slight alignment of the stem towards midline, and this is a sort of a varus, a mild varus placement of the prosthesis, which is important for you to remember because varus is associated with complication. This is a mild varus. The incorporation, as you can see here, is perfect, and I don't think this should have any sort of big reason for worries. If you look across here, you have got a resurfacing hip where they have replaced the femoral head, the acetabular cup, but they kept the femoral neck and the shaft of the femur. If you look at the contralateral side, is normal with good alignment. That this, I don't think you need to do any complex measurement to realize that this is not okay, and they've done the best that they could do, and there is massive osteolysis in here. Okay, let's go to next slide. Next slide, sorry. This is a cemented hip. You can see the cemented hip with very good incorporation of the stem, and basically no loosening or no major problem. Early degenerative changes started to creep here. A little bit of osteolysis occurring in this, but generally well example of the total hip replacement, cemented total hip replacement. Now, what we've discussed, length congruence, very important. You can see the good congruence between the acetabular, the femoral component and the acetabular component with good positioning. And what I said here, the further details, as we discussed about the version, the acetabular retroversion, the prosthetic stem alignment, the center of rotation, the vertical and horizontal center of rotation, acetabular cup version and so on, keep it in reserve only if the orthopedic surgeon is asking you to do this measurement, because they are complex, and on a plain film radiograph that you report on a normal reporting session, those will be difficult to incorporate in your practice. Right, okay. Other things that are important. Other things that are important is usual complication of the prosthesis, like loosening, infection, metallosis and alval, sclerosis and proliferation, which are good news. And later on, we're going to discuss and give examples of metallic implant failure and dislocations and so on. So let's go over a few examples of complication that can occur and how you read them. I'm just going to put this as a sort of a reference so that I can kind of compare and contrast with what I see as abnormal on another hip replacement. So if you look at this is cemented total hip replacement, this is an uncemented total hip replacement. If you look at the back of the greater trochanter here, you start seeing areas of osteolysis. So already this means that the prosthesis in time is going to get loosening once you see the area of osteolysis, and you can start seeing area of osteolysis also here. There is still good incorporation of the shaft here with no evidence of abnormality to suggest loosening here. Remember, if there is a gap of less than 2 millimeters between the shaft and the cortical bone, or between the shaft and the cement, that is okay. You should not report it as loosening. So look for osteolysis here, look for osteolysis here along the prosthetic components. Okay, next slide. Right cemented hip. If you bear in mind the previous slice, look there. And now look here, you can clearly see that there is osteolysis and there is loosening of the stem component in the femur here. There is osteolysis here where the supraacetabular screw here is placed. So this starts to have problems. And if you look also carefully here of the placement of the stem, there is a little bit more contact on this side and on this side. This is a valgus, slight valgus on the stem of the prosthesis, which is okay at this stage. Okay. Next slide. Loosening of the total hip replacement. This is actually quite massive with osteolysis, and also here and on this side. So this is loosening of the prosthesis. Apologies for this distortion on the slide. That is a more threatening complication of the prosthesis, and what I would like to show you here, this kind of mushy appearance with osteolysis and loosening, extrusion of cement, protrusion of the acetabular component into the pelvis. and a clinical syndrome of pain and temperature. So that should alert you of the risk of infection. Is very difficult unless you see gas in the soft tissues and bone destruction to call it osteomyelitis on a plain film, and you probably need more support on cross-sectional images and eventually isotope bone scanning to call it infection and go further to alert the orthopod that you are really worried. But in the presence of these findings and osteolysis, this kind of permeative appearance, if I may call it this way, lack of definition of the medial shaft of the femur, then you should be worried about infection and you should go for further cross-sectional imaging at this stage, I assume. Loosening with infection, a second case with now some abnormalities of the soft tissues, as you can see, which should again prompt you to perform further studies and alert the orthopod. Right. This is a resurface. We've seen this picture, which is a little bit abnormal and in terms of placement and angulation. But let alone this, I'm going to draw your attention to the soft tissues here, and you can see not really bone or body debris, but abnormal kind of spotty, soft kind of tissue inclusions, which are actually a find it is called metallosis. So there are deposits of metal from the orthopedic procedure, which can cause a reaction very similar to a joint effusion with a little bit of debris, which is recognized on MRI, but is also recognized, and you can have a look on the plain field and you should report it. Okay, so this is an example of metallosis associated with the resurfacing procedure of the hip. For the plain film lucencies, in the right acetabulum, we can see them here, spotted here with alongside the soft tissue more prominence, yeah, again in keeping with metallosis. This is something different. We've done this protocol because we were a little worried there is more to this hip joint once we've seen the lucencies here and there than simple metallosis. And what you can see a little lump here of soft tissue, which is low on T1 and high on T2, which is in keeping with what is called pseudotumor or alval. So this was a pseudotumor, is one of the examples I have got, and I want to keep it basic and do this correlation. And I hope I'm going to show you only one cross-sectional correlation and keep it simple as I promised. Okay, let's go now to the good news. Are there some good news about this prosthetic hip replacement? Yes, there are. I'm going to draw your attention again to the standard comparison that I put up here, and I'm going to show you this bit. Can you see that this valgus placed stem hits this bone and the bone presents a reaction? If you look at the cortex here and you look at the cortex here, this is thickened. That area is called stress shielding and is good news, means that the prosthesis is solidly implanted and is accepted by the body, by the bony structure around here. So stress shielding, good news. More good news on this side. So if you look at this side, it's got the stress shielding in here on this valgus placement and a little bit of deformity. The problem needs addressing. On the contralateral side, there is increased cortical thickness. Look at the cortex here, look at the cortex here. So there is good incorporation of the stem with a strong bony reaction with thickened cortical bone. This is called spot welding. So this again is good news, means the prosthesis, the stem, the femoral stem is well incorporated and is got good stability. Okay, so remember the basic two good things: stress shielding, this unilateral increase in the cortical thickness, and spot welding, this bicortical increase in cortical thickness in a sort of a a straight placement of the prosthesis without varus or valgus. So two good news, yeah. I'm going to show you examples of other type of prostheses and a few of their complications. These are cannulator screws. They normally place cannulator screws when we diagnose an early Garden 1 or non-displaced fracture of the neck of the femur, and we want to save the femoral head. So this is a good procedure because it's done percutaneously. They don't open the focus of fracture. You place these 3 cannulator screws and all is hunky-dory and the femoral head is preserved. It is preserved in a large number of cases. This has started to get a vascular necrosis, so you can see the collapse of the femoral head and the early start of having this protruded screws into the cavity, and basically this patient needs to go for a total hip replacement now. So complication of the cannulator screw. Another, we've discussed this partial type of total hip replacement, where the femoral head is replaced with a stem preserving the femoral neck and the femoral shaft, and with replacement of the acetabulum, so resurfacing. Resurfacing can have their own problems like loosening and migration with, as you can see, with valgus deformity and basically an abnormal position of the stem against the femoral, against the acetabular cup. Another example, good placement and abnormalities. Remember the metallosis that we've discussed. We're coming now to failure of the implants. There are lots of failure of the implants, and you can classify into this failure and dislocations, which you can see here. This is a custom-made prosthesis that you will see in Stanmore for complicated cases such as resection of the osteosarcomas of the proximal femur and reconstructions. And this is one that has dislocated. There's another one that is dislocated in a right total hip replacement. Another left dislocated custom-made stem, an example from Stanmore, courtesy of one of my colleagues from there. Another type of complication is what is called the prosthetic and periprosthetic fractures. This is the periprosthetic fracture you can see here. This is one that has healed. There's another periprosthetic fracture here, another periprosthetic fracture here. This is another fracture. You can see the total hip replacement and a patient with a unicondylar knee replacement would have fracture basically to the shaft of the femur here. And this will need major intervention. Now, correlation with SPECT-CT, you can see a unicortical failure of the femoral shaft here along the prosthesis, long stem prosthesis, which is correlated with an abnormality on the SPECT-CT. I'm going to touch briefly on the femoral nail. This is one type of femoral nail with anchors in distally. The fracture is beautifully treated, but sadly there is failure of the distal screws which have fractured. And finally, the DHS, you see commonly DHS, a few words of wisdom on the DHS. This is a reasonable placement of the DHS. Normally the orthopods want it placed somewhere nearer the lower portion of the femoral neck, somewhere here. Apparently gives you more stability and doesn't perforate through the neck. Nicely healed pertrochanteric fracture, nice position DHS. This one has failed in the sense that the femoral screw basically has protruded. There is dislocation of the femoral head, and this basically is a total hip replacement revision. Same DHS screw, the normally placed against the abnormal one. And this will be the last slide. I think I overrun a little bit, where you can see a normal DHS, but you can see fibrous dysplasia. So it's courtesy of my one of my colleagues in Dartford. So a DHS in normal position, but with polyostatic fibrous dysplasia for you, for the radiologist in audience. remember a few things. Is if you close your eyes and you want to forget some of the stuff that perhaps was a little bit too difficult. Remember that we have discussed about position of the implants, and keep it basic. Keep your assessment of it basic, and go for detailed assessment of the acetabular and the femoral components if the orthopodist is asking you. Otherwise, keep basic to left leg limb length measurement, leg length measurement, and also keep it basic to the congruence of the components of the hip replacement, and to the basic orientation of the femoral stem component in terms of centrality, valgus versus varus, and so on. Keep basic on the assessment of loosening and the basic complication of loosening and infection, with other complication of fractures and failure of metallic implants. Remember the type of good news vascular, of favorable good bone reaction, stress shielding and spot welding that we discussed. And finally, you will have an easy time to comment basically on the dislocations and bone failure fractures and periprosthetic fractures. That was all for me this today. Ask me any questions. I've got, I think, 5 minutes or maybe 7 minutes for questions.
Thank you so much, Gabi. Thank you also for keeping the time. It was really good presentation. You went through all the type of implants and type of surgery in the elective settings. Thank you for your presentation. And as you said, if we are not used to do the measurements unless they ask us to do it, but it's good to know that they exist. And from time to time, they might ask us to do some measurements. So thank you for that. So I don't know if there's any questions for the audience. Please unmute yourself or just put it in the chat. Well, it seems that it's very clear for everyone, which is good news. I think people is learning from this series of lectures about how to identify Metalwork complications. So if there are no questions, we don't have the other speaker. Unfortunately, there has been an inconvenience, but we hope to reschedule some of the sessions. So thank you for today. Please don't forget to fill in the feedback. And these sessions are recorded and they're posted in YouTube under Metalwork Orthopedic Radiology. So you can watch them again. So thank you very much. And thank you so much, Gabi, again, for your presentation. Bye-bye.
Thank you for your patience with me. Thank you. Bye.